Hello everyone. Today we'll be talking about hypertension in pregnancy or hypertensive disorders in pregnancy. Our main focus will be preeclampsia. Hypertension is one of the common medical complications of pregnancy and contributes significantly to maternal and perinatal morbidity and mortality. So, classification of hypertension in pregnancy. Hypertension is BP greater than 140 over 90 millimeters mercury, measured 2 times with at least a 6-hour interval. Proteinuria, urinary excretion of greater than or equal to 0.3 grams protein in 24-hour specimen or 0.1 grams per liter. Gestational hypertension, blood pressure greater than or equal to 140 over 90 millimeters mercury for the first time in pregnancy after 20 weeks without proteinuria. Pre-eclampsia, gestational hypertension with proteinuria. Eclampsia, women with preeclampsia complicated with convulsions and or coma. Chronic hypertension, non-hypertension before pregnancy or hypertension diagnosed first time before 20 weeks of pregnancy. Superimposed preeclampsia or eclampsia, occurrence of new onset of proteinuria in women with chronic hypertension. Disorder, chronic hypertension with superimposed preeclampsia and eclampsia. The common causes of chronic hypertension: essential hypertension, chronic renal disease, coarctation of aorta, endocrine disorders such as diabetes mellitus, pheochromocytoma, thyrotoxicosis, connective tissue diseases, lupus erythematosus. The criteria for diagnosis of superimposed preeclampsia is new onset of proteinuria greater than 0.5 grams per 24-hour specimen, aggravation of hypertension, thrombocytopenia, or release of liver enzymes. Pre-eclampsia definition. Preeclampsia is a multisystem disorder of unknown etiology characterized by development of hypertension to the extent of 140 over 90 millimeters mercury or more with proteinuria after the 20th week in a previously normotensive and non-proteinuric woman. The preeclamptic features may appear even before the 20th week, as in cases of hereditary deformed mole and acute polyhydramnios. The term pregnancy-induced hypertension is defined as hypertension that develops as a direct result of the gravid state. It includes gestational hypertension, preeclampsia, and eclampsia. Our main focus of today's lecture will be preeclampsia. So what is the diagnostic criteria of preeclampsia? Hypertension, an absolute rise of blood pressure of at least 140 over 90 millimeters mercury, edema, proteinuria. So what's the incidence? The incidence of preeclampsia in hospital practice varies widely from 5 to 15%. The incidence in primigravida is about 10% and in multigravida is 5%. Risk factors for preeclampsia: primigravida, family history, placental abnormalities, obesity, pre-existing vascular disease, new paternity, thrombophilias. The etiological factors for preeclampsia: failure of trophoblast invasion, vascular endothelial damage, inflammatory mediators, immunological tolerance between maternal and fetal tissues, coagulation abnormalities, increased oxygen-free radicals, genetic predisposition, dietary deficiency or excess. So, etiopathogenesis of preeclampsia. As we talked about the diagnostic criteria, we said there will be hypertension, there will be proteinuria, and edema, as you can see here. So we're going to talk about how they come about. Hypertension. The underlying basic pathologies: endothelial dysfunction and intense vasospasm, affecting almost all the vessels, particularly those of uterus, kidney, placental bed, and brain. The following other considerations: increased circulating fresh substances, increased sensitivity of the vascular system to normally circulating precious substances, trophoblast invasion and uterine vascular changes. Normally, there is invasion of the endovascular trophoblasts into the walls of the spiral arterioles of the uteroplacental bed. In the first trimester, that is 10 to 12 weeks, endovascular trophoblasts invade up to decidual segment, and in the second trimester, 16 to 18 weeks, another wave of trophoblasts invades up to the myometrial segments. So basically, in the first trimester, the invasion is up to the decidua, while during 16 to 18 weeks, the invasion gets up to the myometrium. This process replaces the endothelial lining and the muscular arterial wall by fibrinoid formation. The spiral arterioles thereby become distended, tortuous, and funnel-shaped. This physiological change transforms the spiral arterioles into a low-resistance, low-pressure, high-flow system. In pre-eclampsia, there is failure of the second wave of endovascular trophoblast migration, and there is reduction of blood supply to the fetoplacental unit. So in pre-eclampsia 1, there is an imbalance in different components of prostaglandins. 2, there is increased vascular sensitivity to the pressure agent angiotensin II. Angiotensinase activity is depressed following proteinuria with elimination of alpha-2 globulin. 3. Nitric oxide is synthesized in the vascular endothelium and syncytial trophoblast from L-arginine. It significantly relaxes the vascular smooth muscle, inhibits platelet aggregation, and prevents intervenous thrombosis. Deficiency of nitric oxide contributes to the development of hypertension. 4. Endothelin-1. Endothelin-1 is synthesized by endothelial cells and it is a potent vasoconstrictor. Compared to angiotensin II, endothelin-1 also contributes to the cause of hypertension. 5. Inflammatory mediators. Cytokines such as tumor necrosis factor alpha, interleukins, IL-6, and others derived from activated leukocytes cause endothelial injury. Abnormal lipid metabolism results in more oxidative stress. Lipid peroxide, reactive oxygen species, and superoxide anion radicals cause endothelial injury and dysfunction. Platelet and neutrophil activation, cytokine, superoxide radical production, and endothelial damage are in a vicious cycle. 7 others such as mutation of factor V leading increases the risk. So, I've talked about 7 factors that contribute to preeclampsia. Let's just look at the imbalance in different components of prostaglandins, increased vascular sensitivity to angiotensin II, nitric oxide, endothelin-1, inflammatory mediators, abnormal lipid metabolism, and mutation of factor V leading. So hence, preeclampsia is characterized by endothelial dysfunction and vasospasm. Endothelial dysfunction is due to oxidative stress and the inflammatory mediators. Vasospasm results from the imbalance of vasodilators, prostaglandin I2, nitric oxide, and vasoconstrictors such as angiotensin II, thromboxane A2, endothelin-1. Both are in a vicious cycle. So what's the concept of edema? How does edema come about? We just talked about hypertension. So edema, the cause of excessive accumulation of fluids in the extracellular tissue spaces is not clear. Probable explanations are increased oxidative stress leads to endothelial injury, which leads to increased capillary permeability. On this basis, the leaky capillaries and decreased blood osmotic pressure are the probable explanations. Proteinuria. The probable chain of events is as follows: spasm of the afferent glomerular arterioles, anoxic change to the endothelium of the glomerular tuft, glomerular endotheliosis, increased capillary permeability, increased leakage of proteins. Tubular reabsorption is simultaneously depressed. Albumin constitutes 50 to 60% and alpha globulin constitutes 10 to 15% of the total proteins excreted in the urine. So this is basically etiology of preeclampsia that we were just talking about. So what is the management? Principles of management are the same as that of preeclampsia and eclampsia. Anti-seizure prophylaxis with magnesium sulfate is started. Careful assessment of maternal and fetal status followed by delivery is done. Administration of corticosteroids improves perinatal and maternal outcome. Caesarean section is the common mode of delivery. Recurrence risk of HELLP syndrome is 3 to 19%. So expected management has been carried out selectively when pregnancy is less than 34 weeks with bed rest, plasma volume expansion, antithrombotic agents, immunosuppressive agents, and others. What are the complications of preeclampsia? Maternal complications are abruptio placenta, disseminated intravascular coagulation, acute renal failure, severe ascites, pulmonary edema, pleural effusion, cerebral edema, laryngeal edema, retinal detachment, subcapsular liver hematoma, adult respiratory distress syndrome, sepsis, and death. Perinatal complications are morbidity and mortality are significantly increased. This is due to preterm delivery, prematurity, respiratory distress syndrome, and sepsis. Brain. Clinical manifestations of headaches, scotomata, blindness, convulsions are due to posterior reversible encephalopathy syndrome involving the parietal and occipital lobes. Heart. Subendothelial hemorrhages may occur. Focal necrosis and hemorrhage in the myocardium may affect the conducting system, leading to heart failure. Lungs. There is evidence of edema or hemorrhagic bronchopneumonia. This is due to low oncotic pressure and leaky capillaries. Other organs such as the adrenal glands show hemorrhage and necrosis. Stomach shows features of hemorrhagic gastritis. Water and electrolyte imbalance. The retention is likely due to renal vasoconstriction leading to reduction of glomerular filtration rate. The salt retention increases extracellular fluid volume, increases sensitivity to angiotensin II, and may increase peripheral resistance by causing arteriolar endothelial swelling. The net effect is intravascular dehydration and extravascular overhydration. Thus, there is hemoconcentration and rise in hematocrit value. Erythrocyte destruction. There is evidence of increased erythrocyte destruction following eclampsia with resultant hemoglobinemia and hemoglobinuria. Coagulation. There is evidence of disseminated intravascular coagulopathy affecting widespread organs of the body as opposed to selective disseminated intravascular coagulation only at the placental site in normal pregnancy. The process appears to be initiated by the release of thromboplastin into the circulation. Hormones. There is a conflict regarding the hormonal status in preeclampsia. Estrogen and progesterone levels are lowered, whereas chorionic gonadotropin level may be increased. The serum level of human placental lactogen is decreased. Biochemical values. Non-protein nitrogen and urea levels of normal pregnancy of 25 mg per deciliter and 20 mg per deciliter respectively are maintained in mild preeclampsia. However, in severe preeclampsia, both the levels are increased. Blood uric acid level is raised beyond the normal level of 4 mg per deciliter. Uric acid is secreted by the distal tubules. Raised serum uric acid level indicates renal involvement. High levels of serum uric acid is found to correlate with the severity of preeclampsia, volume contraction, and fetal jeopardy. Serum creatinine is elevated in severe preeclampsia. Blood chlorides are increased due to delay in the excretion of sodium. Serum protein level is lowered, particularly the albumin fraction. Oxidative stress. Hyperhomocystinemia found in preeclampsia causes oxidative stress and endothelial damage. Clinical types of preeclampsia. The clinical classification of preeclampsia is arbitrary and is principally dependent on the level of blood pressure for management purposes, but proteinuria is more significant than blood pressure to predict fetal outcome. Mild preeclampsia. This includes cases of sustained rise of blood pressure of more than 140/90 mm mercury but less than 160 mm mercury systolic or 110 mm mercury diastolic without significant proteinuria. Severe preeclampsia. 1. A persistent systolic blood pressure of greater than 160 mm mercury or diastolic pressure of greater than 110 mm mercury. 2. Protein excretion of greater than 5 grams in 24 hours. 3. Oliguria of passing urine of less than 400 ml in 24 hours. Platelet count less than 100,000 per millimeter cubic. 5. HELP syndrome. 6. Cerebral or visual disturbances. 7. Persistent severe epigastric pain. 8. Retinal hemorrhages, exudates of papilledema. 9. Intrauterine growth restriction of the fetus. 10. Pulmonary edema. So as you can see on point number 5, I've mentioned HELP syndrome. If you'd like to know more about it, I'll be making a separate video on HELP syndrome. From the prognostic point of view, a diastolic rise of blood pressure is more important than the systolic rise. Clinical features of preeclampsia frequently occurs in premigravida 70%. It is more often associated with obstetrical medical complications such as multiple pregnancy, polyhydramnios, pre-existing hypertension, diabetes, etc. The clinical manifestations appear usually after the 20th week. Onset. The onset is usually insidious and the syndrome runs a slow course. On rare occasion, however, the onset becomes acute and follows a rapid course. Preeclampsia is principally a syndrome of signs, and when symptoms appear, it is usually late. Mild symptoms. Slight swelling over the ankles which persists on rising from the bed in the morning, or tightness of the ring on the finger is the early manifestation of preeclampsia edema. Gradually, the swelling may extend to the face, abdominal wall, vulva, and even the whole body. Alarming symptoms. The following are the ominous symptoms which may be evident either singly or in combination. These are usually associated with acute onset of the syndrome: 1. Headache, 2. Disturbed sleep, 3. Diminished urinary output, 4. Epigastric pain, 5. Eye symptoms such as blurring, scotomata, dimness of vision, or at times complete blindness. Signs: abnormal weight gain, rise of blood pressure, edema. There is no manifestation of chronic cardiovascular or renal pathology, pulmonary edema, abdominal examination. Thus, the manifestation of preeclampsia usually appears in the following order: rapid gain in weight, visible edema and or hypertension, then proteinuria. As you can see, proteinuria is a late manifestation. So investigations are urinalysis, ophthalmoscopic examination, blood values, antenatal fetal monitoring. Course of the disease. Preeclampsia is usually insidious in onset and runs a slow course. Rarely, the onset may be acute and follows a rapid course of events. If detected early with prompt and effective treatment, the preeclamptic features may subside completely. If left untreated and uncared for, the preeclamptic features remain stationary. The aggravation of the preeclamptic features with appearance of symptoms of acute fulminating preeclampsia as mentioned earlier. See eclampsia. It may occur following acute fulminating preeclampsia or bypassing it. In fact, eclampsia can occur even with a blood pressure of 140/90 mm mercury. The spontaneous remission of the preeclamptic features are a rare and fortunate event. Complications of preeclampsia. The complications are more likely to occur if the patient are left untreated and uncared for. So immediate complications under maternal, fetal, and remote. So immediate maternal complications during pregnancy: eclampsia, accidental hemorrhage, oliguria and anuria, dimness of vision and even blindness, preterm labor, HELLP syndrome, cerebral hemorrhage, acute respiratory distress syndrome. During labor: eclampsia, postpartum hemorrhage in the puerperium, eclampsia, shock, sepsis. So fetal complications. The fetal risk is related to the severity of preeclampsia, duration of the disease, and degree of proteinuria. The following hazards may occur: intrauterine fetal death, intrauterine growth restriction, asphyxia, and prematurity. Then remote complications are residual hypertension, recurrent preeclampsia, chronic renal disease, risk of placental abruption. So prognosis. The prognosis of preeclampsia depends on the period of gestation, severity of disease, and response to treatment. Immediate: if the preeclampsia is detected early with prompt and effective treatment, the preeclamptic features subside completely and the prognosis is not unfavorable, both for the mother and the baby. Maternal mortality. Increased maternal deaths are mainly related to eclampsia, accidental hemorrhage, acute renal failure, pulmonary edema, disseminated intravascular coagulopathy, and HELLP syndrome. Perinatal mortality. Although the maternal mortality has been reduced significantly, the perinatal mortality still remains very high even in the developed countries. 7 to 10%. In the developing countries, the perinatal mortality remains to the extent of about 20%, about 50% of which being stillborn. So prophylactic measures for prevention of preeclampsia: regular antenatal checkup, antithrombotic agents, heparin or low molecular weight heparin, calcium supplementation, antioxidants, balanced diet. So management of preeclampsia. So long as the etiology of preeclampsia remains obscure, the treatment is mostly empirical and symptomatic. While measures are directed to relieve edema and hypertension, there is no specific therapy for proteinuria, which automatically subsides with the control of hypertension. So the objectives are to stabilize hypertension and to prevent its progression to severe preeclampsia. 2. To prevent the complications. 3. To prevent eclampsia. 4. Delivery of a healthy baby in optimal time. 5. Restoration of the health of the mother in puerperium. Hospital or home treatment. Ideally, all patients of preeclampsia are to be admitted in the hospital for effective supervision and treatment. There is no place of domiciliary treatment in an established case of preeclampsia. However, in some centers, cases of preeclampsia are managed in the DK unit. Rest, high protein diet are prescribed and the patient is investigated and checked. If the treatment fails to improve, the patient is to be admitted. So hospital management. Rest, admission in hospital and rest is helpful for continued evaluation and treatment of the patient. While in bed, patients should be in left lateral position as much as possible to lessen the effects of vena cava compression. Rest increases the renal blood flow. Diuresis increases the uterine blood flow, improves the placental perfusion, and reduces the blood pressure. Diet. The diet should contain adequate amount of daily protein, about 100 grams. Usual salt intake is permitted. Fluids need not be restricted. Total calorie approximately 1,600 calories per day. Diuretics. The diuretic should not be used injudiciously as they cause harm to the baby by diminishing placental perfusion and by electrolyte imbalance. Antihypertensive drugs have limited value in controlling blood pressure due to preeclampsia. However, the drugs that are used for hypertension are methyl-dopa, labetalol, nifedipine, and hydralazine. Hypertensive crisis. Any of the following drugs that are mentioned here can be used when the blood pressure is greater than 160 over 110 mm mercury or the mean arterial pressure is greater than or equal to 125 mm mercury. So the drugs mentioned are labetalol, hydralazine, nifedipine, nitroglycerin, sodium nitroprusside. However, you have to avoid labetalol in women having asthma or cardiac failure. Progress chart. The effect of treatment should be evaluated by maintaining a chart which records the following. 1. Daily clinical evaluation for any symptoms such as headache, epigastric pain, visual disturbance, oliguria. 2. Blood pressure at least 4 times a day. 3. State of edema and daily weight record. 4. Fluid intake and urinary output. 5. Urine examination for protein daily and if present to estimate its amount in 24 hours urine. 6. Blood for hematocrit, platelet count, uric acid, creatinine and liver function tests at least once a week. 7. Ophthalmoscopic examination on admission and to be repeated if necessary. 8. Fetal well-being assessment. So duration of treatment. The definitive treatment of preeclampsia is termination of pregnancy, delivery basically. As such, the aim of the above treatment is to continue the pregnancy if possible without affecting the maternal prognosis until the fetus becomes mature enough to survive in extrauterine environment which is greater than 37 weeks. Thus, the duration of treatment depends on 1. The severity of preeclampsia, 2. Duration of pregnancy, 3. Response to treatment, 4. Condition of the cervix. Depending on the response to the treatment, the patients are grouped into the following. Preeclamptic features subside and hypertension is mild. B. Partial control of the preeclamptic features, but the blood pressure maintains a steady high level. C. Persistently increasing blood pressure to severe level, despite the use of antihypertensives and or addition of grave features such as headache, epigastric pain, oliguria, blurring of vision, or HELLP syndrome. So what are the methods of delivery? Induction of labor. Indications are aggravation of the preeclamptic features. 2. Hypertension persists. 3. Acute fulminating preeclampsia. 4. Tendency of pregnancy to overrun the expected date. Caesarean section indications. When an urgent termination is indicated and the cervix is unfavorable to severe preeclampsia. 3. Associated complicating factors such as elderly, primigravida, contracted pelvis, malpresentation. Management during labor. Blood pressure tends to rise during labor and convulsions may occur. So you give prophylactic magnesium sulfate is started when systolic blood pressure is greater than 160 or diastolic greater than 110 or mean arterial pressure greater than 125 mm mercury. Careful monitoring of the fetal well-being is mandatory. Intravenous ergometering following the delivery of the anterior shoulder is withheld as it may cause further rise of blood pressure. In puerperium, the patient is to be watched closely for at least 48 hours, the period during which convulsions usually occur. Oral nifedipine 10 mg at every 6 hours is given until blood pressure remains below the hypertensive levels for at least 48 hours. Magnesium sulfate for at least 24 hours and antihypertensive drugs may be needed in women with severe hypertension and symptoms of acute fulminant preeclampsia during the postpartum period. So scheme of management of preeclampsia. So you give hospitalization or daycare admission. You tell them to rest. You check blood pressure 4 times a day. You do a blood profile in which you're interested in platelet count, coagulation profile, uric acid, creatinine, liver function test, and 24-hour urine for protein. Ophthalmoscopy and fetal well-being assessment, which you do DFMC, non-stress test, cardiotocography, biophysical profile, ultrasonogram Doppler. And you administer an antihypertensive if diastolic blood pressure is greater than 110 millimeters mercury. If this complete control preterm, you discharge and you ask them to attend the antenatal clinic. If they term, you ask them to stay in the hospital or tendency to cross the expected delivery date, then you have to deliver them. Then if blood pressure is persistently high, you try to continue the pregnancy till 37 completed weeks or at least 34 weeks and then deliver. If this persistently increasing blood pressure to severe level despite the use of antihypertensives or addition of ominous symptoms, you do couple counseling, transfer to a tertiary care center, prophylactic anticonvulsant therapy of myself, magnesium